actually take
Yeah.
the blue tubing and make your own. So this is what your typical neb is gonna look like. So this is a mask and this is a mouthpiece. So you want this reservoir tubing, and it's gonna hold the medication instead of it blowing out into the atmosphere. It gets trapped in the coils, and then when they inhale again, it'll pull some of that medication back in. So that's the reservoir piece. But yeah, I just went through a whole box of them. And
Yeah, so did I. That's funny.
So. It's gonna, that aerosol tubing piece needs to be 6 inches to work as a reservoir. Anything longer is not gonna help, so kind of keep it to that 6-inch piece. Mask versus mouthpiece should be based on patient ability, preference, and comfort. Just make sure your patient is mouth breathing through both devices, okay? The CDC recommends that nebs be clean and disinfected, rinsed with sterile water, or air dried between patient uses. I told you they'll hang them up on the nebs, on the flow meter back there to air dry between use. We talked about ultrasonic nebs last semester. Remember, those use the physioelectric crystal to generate an aerosol. Your vibrating mesh nebulizers are gonna be an Aerogen. We'll use those at Gulf Coast Medical Center on BiPAPs and ventilator patients once we get into critical care. So you'll probably just use your basic neb sets this semester.
Is that the one with the syringe? The syringe dose?
No,
Syringe pump?
no.
Okay.
That's a continuous.
Okay.
The Aerogen is a little brown box.
Oh, okay. Alright.
Oh, dear Lord. My husband just sent a video in our family group text, and it says, public service announcement, how to run the dishwasher. He's not happy how it got loaded when he wasn't home.
So for education for the patient at home, it says, is it still standard just to use dish soap to clean the,
Yep.
okay, for the
A lot
nub?
of times Dawn, dilutes
Yeah,
Dawn
okay.
dish soap.
Okay.
Sometimes they'll do like add a cup of, white vinegar to the wash.
Oh, okay.
Because white vinegar is an antibacterial property.
Mhm.
When you get in the hospital setting and you are getting dirty, nasty scrubs, I would come home and I would wash my scrubs with a cup of white vinegar because it has antibacterial and antiviral properties. You can buy a gallon of white vinegar for like $2, but if you buy laundry detergent for healthcare providers, you get the little tiny bottle and it's like $9.
So you just put it in with a dish soap, with the, not dish
And your
soap.
clothes don't smell like it afterwards.
Oh, wow, I'm gonna try that.
So-
White vinegar. How much do you use, just a cup?
A cup for a full load.
Okay,
Yep.
definitely
Yep.
would do that.
No, I put it into the bowl, just go ahead and put it in there. I also use it with my towels on a daily basis.
It probably cleans the washer too, that's a good idea, actually. Disinfects the washer. Yeah.
Okay, so look at table 40.3, the advantages and disadvantages of aerosol drug delivery systems. Familiarize yourself with those. When we get to infants and children, if you have a 6-month-old baby, they're probably not gonna put a mask on and do it right, so we do what we call blow-by treatments for babies. And what you usually do is you just block off this back side where the mouthpiece is. So what I usually do is I will grab a glove, a clean glove, because you don't want to do something dirty. And all you really have to do is put this mouthpiece on there and do it on for there. And nothing's going to come out this back end, and then you're going to blow this into the baby's face. Okay, and that will be a blow-by treatment. Because
that's
if
a
you've
great
ever
idea.
dealt with children, they're not gonna put a mask on their face and hold still. Okay? We also, in a perfect world, would not like our children crying when they get a breathing treatment. I hear people say all the time, if they're crying, they're taking in big, deep breaths. Well, think about a whole cry. They're not taking in big, deep breaths. They're just doing the whole shallow, kind of thing. So they're not able to get that deposition. So a lot of times kids in those young age range have stranger danger. You walk in And, we always go in and give breathing treatments after the nurses have drawn blood and they hold them down. So you walk in and you're automatically a bad guy. You know, they see you and they're not happy. But blow by is how we like to, and you can kind of stand away. Or sometimes you ask the parents, like, I've scared the crap out of them. Here, you want to hold this
Oh, yeah.
and do this treatment with them. A lot of times that will help.
That's how we do it. Crap by the
If you have like a 5 or 6 or 7-year-old that can't wear a mask and the parent requests to do a blow by, it's usually because the kid is just a brat and is never told no.
So sleeping too, can you do it when they're sleeping?
You can, I mean, like, there's no way to reason with a 6-month-old to get them to take deeper breaths.
Yeah.
If it's an 8-year-old that you can get to take deeper breaths, then ultimately you would want them
Sure,
woken
yeah.
up. It also depends on the situation. If this kid's been sick in the hospital for 4 days and hasn't slept at all, and they just fell asleep, I'm not gonna wake them up
Sure.
to do the treatment too. So you kinda look at the whole grand scheme of that. But yeah, you can't reason with a 6-month-old and be like, okay, now you take a deep breath and I'm gonna give you a sucker or a sticker
Yeah.
afterwards. You can get them to. Some 3-year-olds and all that you can.
So any opportunity, the best opportunity.
You also, I mean,
for
when
it.
kids don't feel good, they're not gonna behave the best
Yeah.
either. If they just got stuck and got shots or had blood drawn, they're gonna hate anybody that's in scrubs. So you kinda have to play the game the way you can, honestly.
Ms. Barber, if you do a blow by, most of it is lost, so would you give a higher dose?
No, and I mean, but most of it's lost anyway. So the thought is if you can get what you can, but don't hold, I'll go in and I'll see people holding the blow by up over the patient's nose. It's gotta go to the mouth, so.
So if they're like predominantly like nose breathers, like up to 1-year-old, would it be using a mask? Is that something that's done or no?
Yes, but I mean, you kinda have to, you know, even some older, smaller kids, you can, you know,
Yeah, sure,
let's
yeah.
take deep
Okay.
breaths, try to encourage that. What I hate to see is you go in and the baby has a pacifier in their mouth and they're asleep and the therapist is blowing over their nose. And at that point, you might as well be giving your Barbie doll a treatment, because you're gonna get the same effect, so.
What about the streets? What are those people that like?
So ideally, we would want everybody to take a mouthpiece treatment. If they can't do the mask. We're just gonna make sure that we understand that they're breathing through their nose. And then your infant and small children will do a blow-by for.
Okay.
So I had to do blow-by treatments on adults before for special extenuating circumstances. The SVN can be given to neonate, to all ages. Your MDIs and your DPIs and your breath activated nebs, they recommend for ages like 4 years old and up, because they have to be able to follow directions. Box 40.7 shows your factors associated with reduced drug deposition in the lungs. That could be your mechanical ventilation, artificial airways, reduced airway diameter, high gas flows, limit of delivery device, those kind of things. Familiarize yourself with those. And then peak flow monitoring, it's peak expiratory flow rates. You'll see it's PEFR. You might have an order to do NEBS with PEFR. That's gonna be your peak expiratory flow rates or peak flow monitoring. Peak flow is gonna be the measurement of effort dependent on volume. It's evaluation of patient performance and it's subjective. You'll get to this more when you're in your pulmonary function part of Ms. Porter's test or class. It's used to assess the effectiveness of a treatment, and it's the standard for determining bronchodilator response. So you'll actually have a peak flow meter. You'll have your patient stand up, taking a nice big deep breath, and they blow out as hard and as fast as they can into a handheld device, and they get a number. And it's one of the gold standards for asthma patients to monitor their response to treatments and things like that. But this chapter just kind of introduces you to it, but you'll get into peak flow monitoring a lot more in your Ms. Porter class this afternoon. Not today, but during the course of the semester. It's important to note that if you are doing peak flow monitoring on your patient, they use the exact same monitor every day. It's kind of like your scale at your house and your doctor's scale never match up. You wanna make sure that you're monitoring on the same device each time, because you might get separate readings. And then patient education, the desired outcome for all bronchodilator protocols is restoration of normal airflow and cessation of therapy. We don't want our patients to be on therapy forever, believe it or not. So our goal is to get them back to where they are and off the drugs that they were on. So with the patient education, you have to make sure that you know about the drugs and about the device that they're using to take them. So it's a lot on you to ensure that your patient's taking them right. Because the last thing you wanna do is have a patient that either swallows the dry powder capsule or uses their MDI as a puffer for their perfume. So a lot of information. It's a big, heavy chapter. We do not meet next week. You are off Monday and Tuesday for MLK Day.
Monday and Tuesday?
Monday and Tuesday.
Really?
Don't fight it, don't.
I'm not, I'm just surprised.
You're off. This is the first year they've ever